I'm welcoming you on behalf of myself, Mary Hardy, an integrative oncology physician, Laura Pohl, who is multi-talented, an oncology nurse navigator, a trained chef, and an advanced nurse practitioner, and Christine Meinhardt, who is our fearless leader and who keeps us on track every day. So, thank you for joining us. And this time we're going to do something a little different with this talk because the topic is of great interest to many people. So we're going to be talking about liquid biopsies, which is finding out something about your cancer from a bodily fluid, most basically. And we probably will share this. Um, isn't it? We're going to share this more broadly. So if any of you do not want your picture to show up on the website, you can turn your camera off now. Otherwise, we're going to proceed together like this. And then when we get to the point where we're going to do our own questions at the end of this presentation, we can ask Christine to turn the recording off, and then we'll have our usual question and answer in a more private setting. Is everybody good with that? Great. Okay, and Laura and Christine will help me watch the chat so you can put your questions there. And I'm going to go ahead now and start sharing. Let's see here. Oh, sometimes this thing, I'm okay with it being recorded. And you guys have to also consent, which is nice, I think. Um, okay, so let's see here. My share button. I'm going to get my slides out now. Okay, share. And then, okay. All right, now I'm going to put this in presentation mode. I'm going to turn the little pictures off on my computer so you can see the slides better. Okay, so here's what we're going to be discussing today, liquid biopsies. And I think this really is the cutting edge of cancer diagnostics. And just as we start off from the beginning here, I'm going to tell you two things. This is a very technical topic, and it is also a rapidly developing topic. So I'm going to hopefully today give you a general orientation so you know roughly what this field covers, what it's good for, when to ask about it, especially, and then what it might cost, and about finding additional information, which hopefully we'll have some more for you on our website sooner or later. And if you go for general sites, I'm going to tell you what's good about that and what's bad about that. Okay. So the first place to begin, which is where I think this interest in diagnostics always starts, is why is cancer so deadly? And we all know that cancer is um, common. It's not as common as the common cold, but 2 million people are going to be diagnosed with a new cancer this year. And there are a little over 600,000 deaths per year just in the United States. And those numbers obviously are exponentially higher if we include the rest of the world. We've been doing a better job. Cancer death rates have declined, and our 5-year survival has increased over the last 5 years. And this number, although it's 69% overall for all cancers, some cancers have a really high 5-year survival, like breast cancer, 95%, and other cancers have a much lower survival, acute myelogenous leukemia, pancreatic cancers, things, lung cancer sometimes, not always, and all cancer is is harder to survive if you get to it late. Okay? Cancer is also deadly because there's a lot of health disparities, depending on our access to health care, on how seriously or not seriously our providers take us when we talk about symptoms, and how good or bad our insurance is to cover testing and treatment. It's well described in the literature that if you're of a lower socioeconomic class, that your access is lower, your coverage is lower, and your survival is worse. But difficulty with insurance can go across all patient types and many cancer diagnoses. And all this stuff adds up to late diagnosis, which we really want to avoid, and sometimes undetected recurrence. And again, that's another thing that we'd really like to avoid. This is just a thing looking at the last cancer death rates from the last probably 70 years or so. And it shows that some cancers had a very high rate, which has been sharply declining, of death, prostate lower, colorectal falling, um, things like stomach cancer falling rapidly, liver cancer mostly falling, pancreatic cancer staying about the same, etc. So we're getting better with the death rate, about 1.7% decrease per year. But what if we could diagnose cancer earlier? And what if we could do it with less risk and less discomfort? Those of you who've had biopsies know that sometimes biopsies are not fun. They might be painful. They might require you to be in a special testing situation, um, have a scope put in to do biopsy, etc., or go to the radiology for biopsy. And so, what if we could make that a lot less complicated? So, into that information gap has come something called a liquid biopsy. So, what is this? This is minimally invasive, meaning it's usually no worse than getting a blood test. Although any or collecting your urine in a cup sometimes. Although any cancer, any time that you have any fluid captured, so spit in a cup for head and neck tumors, um, have endoscopy to look at your up at blockage there. Maybe they collect bile that can be submitted, etc. So it's minimally invasive, usually less invasive than a needle biopsy will be, certainly less invasive than an open or surgically collected biopsy would be. And then that's all analyzed, and it's looked. You look for tumor cells or cell parts or different kinds of cells, different proteins, things like DNA, which is the genetic information that causes cells to be built, double-stranded, RNA, single-stranded, and this is the messenger that takes a message from DNA and delivers it within the cell, but also can be delivering a message from that cell to the rest of the body or to other particular areas in the body. Medicare has standards for how good the tests have to be, that these kinds of tests. And I'm going to just do this. This is, again, one of these really complicated technical things. So the definition is sensitivity 74%. That means 74% of the time, if the tumor is there, this test will find it. Okay? Now, this also means that 26% of the time, if the tumor is there, it will miss it. So it's 3 for 1. 3 times they'll find it, 1 time they won't. Um, and specificity is 90%. That means that if we say this is not the tumor, then it actually really is not the tumor. Okay? A little complicated, but this just tells you how good the test has to be, because the test is only as good as it finds the tumor when it's there and doesn't find the tumor when it's not there. Now, how good is the online information about liquid biopsies? There are websites, there are videos, there are communications from different cancer centers. But if you go to look for this information, you're also going to find that this information is not generally of good quality. And 2 times ago, we talked about how do you judge if information is good or not. And in this particular area, one of the things I wanted to really point out to you guys is that the conflicts of interest are very high. What does that mean? That means I may be telling you about this test and how wonderful it is, but I might be the people selling it. And if I don't tell you that I'm the people selling it, then I'm kind of tricking you, because I'm not letting you know that I have a vested interest on what you do with the information I give you. So if I tell you something's great and you decide to do it, but I should tell you that, geez, I'll gain if you get this test. I'll make money if you get this test. So if we look at the information on this side, very teeny tiny lettering, but it says here that how many commercial bias? They found that 61% of the times that this group of researchers looked at the online offerings, the web-based offerings, that 61% of the time, more than half, there was serious commercial bias, and that bias was only talked about 5% of the time. So I think, again, like I told you that 2 times ago, caveat emptor, be careful. The other thing is that this is, again, really technical. And that's a problem because the language used to describe these things is a very high level of language. Meaning, if we look at the post and they put it through some models that tell it what level do you have to be at in school to be able to read this, it was well after high school, 2 and sometimes 6 years after high school. So into college sometimes. And that's hard because the average reading literacy is more like eighth, ninth grade, something like that. So if the language is too technical, it's going to confuse people. It's not going to inform them well. Also, this is mostly or entirely in English, and not everybody speaks English. And the other thing that's particularly interesting to people that they don't talk about in these videos is what this stuff costs or if it's covered by insurance. And we're going to talk about that a little bit today ourselves. Okay, now there's a lot of things that you might think are a liquid biopsy if you if you are whoopsie, sorry, if you just hear that term. So what does that mean? Okay, so what's the difference between liquid biopsy and genetic testing? Um, so genetic testing will look for the makeup, the genes that are in the tumor cell that make up how the tumor behaves. Mostly that's what these genes do. And if there are mutations or changes in these genes, then these cells may make the tumor more aggressive or more likely to grow or more likely to metastasize, or this genetic change may be a target for some of the new biologically active agents that we have now for treating cancer. So you can get genetic information anytime you have enough DNA to do that. If you have a full cell, you probably have the full genetic complement. If you just have DNA, you may or may not have enough DNA. If you go and literally get a piece, like a regular biopsy, a piece of the tissue at surgery or with a needle, you'll definitely have enough information to do genetic testing. So, but liquid biopsies, like I said before, come from any liquid, any fluid that the body produces that could have tumor cells or tumor byproducts or other kinds of proteins, etc. So a liquid biopsy may be able to do DNA testing, and it can include that, but it may not be able to. So that's the possibility. And whichever way you get the genetic testing, it can be helpful in telling if a tumor will respond to a particular drug which target a specific mutation that will help you select the best match of therapy, or it will be able also to tell you if tumors have a lot of genetic variability or variety. Why does that matter? Well, it depends on what kind of therapy you're getting. If you're getting radiation just affects all fast-growing cells. It doesn't really care about the mutations. It just gets them all. Um, Chemotherapy, if it's the conventional first level or first the original kind of chemotherapy where they give drugs like taxanes or carboplatinum or uh, methotrexate, interfering drugs, any kind of drugs like that, the usual kind of drugs that were done, the first line kinds of therapies. Uh, those are usually drugs that really interfere with growth or with sort of general actions of the tumors. And so it doesn't really matter so much about the mutations. Those are kind of like dropping a bomb. It does make a difference if you picked a specific drug which only responds to one mutation and that mutation is not in every cell, or not in the majority of the cells, then that specific medication may not work so well if the tumor has a lot of variety. This is especially important to emphasize because when we talk about cancer, we kind of have this idea that it's like one cell goes bad and then it makes a bazillion copies of itself. And that's true to a degree, but tumors are often, rather than like a single picture, they're often like a mosaic where they have bunches of different kinds of things inside them. So there may be more than one uh, mutation being expressed. And if there's a lot of variety, that could change the choices that are made for therapy. Okay, now, now this is going to give you a little bit clearer look at what this could look like. So here's you. Here's one fluid, saliva. Um, Fluid, if you have a bronchoscopy, they put fluid down there and pull it back out. So tumor cells might be in that. Blood is by far and away the most common and used the most broadly, but urine could be used for, especially for bladder cancers. And then, although it's not exactly a fluid, these tests can also be done in stool. And that's where probably the most commercial application, most generally available commercial application is right now. And then this is all the bazillions of things you might be looking at when you look.
Mary, I think your slides aren't advancing.
Uh-oh. So do you see that little person there? A little human being?
No, it's still on the slide that says, what is the difference between liquid biopsy and
Okay, let
genetic?
me let me let me stop this. Oh, let me go back and see how do I have to get a little bit like this. And then let me go back and so this is the one that was on last. What is the
Yes.
difference? Okay.
Yeah.
Okay, good. Let me see. Then this one should be the next one. Thank you, Laura.
Mm-hmm.
Okay, so now here's back to what I was talking about. This
No, it still didn't. It
it
still
didn't show
didn't.
up?
No. Uh,
Weird. Okay.
yeah.
No, it's not changing at all.
Maybe
No.
just try stop sharing and resharing again.
I
Just
think
Yeah.
that's what I'm gonna do now. That was my second choice. Hi, everybody. Sorry for the technical difficulties. Okay, back to this. Share. Okay.
Yep.
It shows now?
Yep.
Okay, great. All right, and when I do it this way, you can still see it, right, Laura?
Yes.
Okay. Okay, so here's the different kinds of materials that could be tested. Saliva, especially for head and neck. Um, a bronchial lavage fluid, that means when they put a scope in to look and see. Sometimes for tumors in the lung, they'll evaluate that way. They put in liquid to wash out this area. There might be cells in that. This technology could be used for that. Blood is the most common and used for the biggest variety of tumors, and urine is especially appropriate for bladder tumors. But you can also look at stool, which is used probably the most commonly commercially available now. This circle here tells you all the gazillions of things that they could be looking for, and we're going to talk mostly about finding full tumor cells and then tumor cell DNA. But any of the rest of these things, like the RNA, could be looked for, etc. And these immunoglobulins that might come off the tumor, hormones that might be produced by the tumor, etc. And then this could be used, as we're going to repeat this several times. I'm going to mention it briefly now. Finding things early, finding if a tumor has recurred, hopefully early, you can follow the tumor, see how well treatment is working, and then even at the first diagnosis, sometimes this can be used for prognosis as well, like how how likely are you to do well or less well. So I'm gonna put this in just so as you read through some of this stuff, you can see what these terms mean because like I said, very technical. So CTC, this is circulating tumor cell. This is a cell from a cancerous tumor found circulating freely, usually in blood. ctDNA, circulating tumor DNA. This is a piece of DNA from a tumor circulating in blood or other fluid. Um, and DNA is the genetic material that directs the cell to how to divide, how to express itself, etc. It's sort of the basic blueprint for the cell. And then RNA, which is a messenger nucleic acid, so ribonucleic acid, deoxyribonucleic acid. So ribonucleic acid is when the DNA, which you've seen curled up in a helix like this, as it zips open, the RNA goes onto that DNA, takes a quick picture of it, and then that shorter piece of genetic material goes off as a messenger to tell the cell to do certain things, to bind to certain receptors, but it can also be released into the blood and then have effects distant and away from the tumor itself. This is a word you're going to see. They're now starting to test for these things called exosomes. And these are just basically vesicles, which is a fancy word for bubbles that are released, that are pushed out of the tumor, released in the tumor cells, and they can contain anything that's inside the cell. They could contain pieces of broken down DNA or RNA. They can contain things that have been produced by the cells that are released to have activity outside the cell. They can be all kinds of stuff, and it's used for communication between cells. It can be used in cancer specifically to help the tumor avoid immune surveillance, so avoid the immune system finding it. And it can actually help promote metastases. So you want to know if these little bubbles are present and what's in them. And then when sometimes these tests can be very narrowly focused, looking for one cell type or one kind of thing, or it can be a multi-cancer early detection, in which case that means that it's taken when either you're well and you're just doing surveillance, or when you're high risk and you're doing surveillance, or when you might have a symptom that's non-specific, like weight loss, but you don't know what that's all about. And so this could be used to screen for a bunch of cancers. This is the indication that I think is the holy grail. Could we go every year, have a blood test, and find out something about our cancer risk? I don't think we're there yet, but it's the thing that I think many people are aiming towards. Now, I used a couple of words, and I want you to get a look at what those look like. So here's the test tube. You have had blood drawn. And if you've seen your blood, the bottom half is the red blood with the red blood cells and all that kind of stuff in it. And the top half is the straw-colored serum that separates out from the red blood cells. And this is what we look for. This is what we test when we're looking for all these things. So here's the double-stranded DNA. Here's the single-stranded RNA. And these white dots are the tumor cells. Obviously not to scale because, this should be a lot smaller than the white dot, but it's there so you can see it. So then that thing is taken, and they look to try to find cells first, and then they try to find these vesicles, these blobs of things. So here's an exosome where this bubble pops off, and it sometimes pops off as a little vessel. Sometimes it just releases its stuff. And then this is what could be in the bubble: protein, a metabolite, RNA, DNA, a microRNA, really teeny, teeny pieces of RNA. And then what do? They take molecules along with them. They affect the immune response, and they are released around the tumor. So they can also affect the tumor microenvironment, i.e., does it stay more acidic? That favors tumor growth. Does it stay more anoxic, less oxygen? Does it help promote the growth of new blood vessels to bring more nutrients and materials to this tumor? And does it promote, for example, the tumor to metastasize, or does it protect the tumor so that it's kind of half hidden so that the immune system can't see it? So this is where I would like you guys to start paying attention. So with all that technical stuff behind us, you don't really have to know exactly what pieces of material they're looking for, exactly how the test is done. But if you are in one of these things I'm going to talk about now, then this is where you want to talk to your doctor about looking for these kinds of things, okay? So when is it indicated? It can be indicated for a diagnosis, um, presumptively and hopefully early, even before symptoms are present. Sometimes even before you get like a big tumor lump or something. So the idea is that if you start to have any kinds of symptoms, or even just do a routine screening, you're at high risk for lung cancer, you were a smoker for many years, you do this test and it might help find the lung cancer early before you might even see a big lesion on a chest x-ray. So that's an early diagnosis. And it's especially useful when the tissue is hard to get, or if you had a biopsy and now you're going to a different cancer center and they want to find out something about your tumor, but the cells, there's no material left. There's only stuff that's been handled in a way that makes it not useful, for example, to do genetic testing. So you might do this liquid biopsy to hopefully get cells that they could do some of this genetic testing on. It can also be helpful to tell prognosis. If you do a liquid biopsy and there's a lot of circulating tumor cells, it's been shown in studies that the higher the number of circulating tumor cells, the worse the prognosis. So if you have a lot of tumor cells leaking, that could tell you that there's a big tumor there, and that would make your prognosis more challenging. It might help the treatment team to decide whether to be more aggressive early or wait till later. And they also can help you make treatment decisions, not just that decision, but other treatment decisions like, are you available for particular targeted therapy? And that's a really very valuable use, but it also can be used to follow your response to treatment as your treatment is ongoing. So you only get radiation, you only get your PET scan every 3 months usually. If you started therapy and the oncologist is thinks it may work but isn't completely sure it's working, they can potentially use some of this liquid biopsy material and see, have your circulating tumor cells gone down? Does the tumor look less active or less prone to metastases, for example? So can you find out information about how you're doing responding to therapy? And that may allow for a treatment change earlier rather than having to wait the full 3 months or more to get a more traditional view of treatment. Has the tumor shrunk, for example? You may be able to get an indication even sooner. And then once you've done with your treatment and you want to be monitored for relapse, certainly a lot of us already would get testing done looking at markers like CA 19-9 for some kinds of gastrointestinal tumors, or other markers, CA-125 for ovarian cancer, or breast cancer markers. But it's potentially possible that these things that could be found in liquid biopsy might be present sooner than those markers would rise, or before they would go into an abnormal level. Or a treatment decision. Your markers have gone up. Does that mean that the treatment's not working? Well, you could pair this marker with a liquid biopsy, and that might give you a better handle on what's going on. Okay. Now, this is just looking in more detail at the application, so you can see here that you can either this slide came from an article about pancreatic cancer, so you see the little pancreas there. So if you had a high risk for pancreatic cancer, you could, for example, you could be tested even when even when it's not clear that you actually have something. Or you could be tested when there's potentially something going on and you want to evaluate it more. I'll give you an example using pancreatic cancer. So about 25% of very early pancreatic cancers will cause a change in how the person handles their blood sugar. So their blood sugar will go up. And if you're middle-aged, they'll think, "Oh, well, you've just gotten diabetes." Okay. But that's not the case. 25% of those patients, 25% of the pancreatic cancer patients who are still too early to diagnose, that could be the first sign. So you could do a liquid tumor biopsy, and if you don't see pancreatic cells, fine, just treat people for diabetes. If you do, then you can go hunting for this pancreatic tumor and hopefully find it early when it's still able to be taken out. Then treatment and monitoring, like we said, is surgery the best choice? Is chemotherapy the best choice? What kind of chemotherapy? Radiotherapy. Once these are done, for example, if you have surgery, does the blood become completely clear? If you get adjunctive chemotherapy, have your cell counts dropped? And if you get radiotherapy, after that treatment is finished, does it look like the process has cleared? And then prognosis and evaluation, as we said. Okay, what are the benefits? Early detection, less invasive, and therefore it's a better quality of life for the patient, for you. You don't have to go get a needle stuck in you, which, even though I'm a doctor, I have to say, being on the patient side of the needle isn't fun, for sure. You can get genetic information, which helps you do precision therapy, that treatment matching we talked about. You can get an assessment of the tumor to see how variable it is. You can real-time monitor yourself during treatment. Um, and for example, if you're getting treatment and you don't feel any better, you don't feel like you're getting a handle on things, like if weight loss was one of your symptoms, if your weight loss continues, then you could check to see if your tumor was responding, or if in fact it was getting worse, because in one study, um, it was reported that these kinds of liquid biopsies could detect a tumor progression, a tumor getting worse, growing more, metastasizing more, 5 months sooner than conventional imaging. Why is that important? Well, this is 5 months worth of treatment you get that you wouldn't necessarily get until that much later, when you have to wait for either an X-ray picture, an MRI, a PET scan, etc. We'll tell you about prognosis evaluation and early relapse detection. Those are very useful things. So if any of these are interest to you as you're getting treated, you should talk it over with your doctor. I also said that liquid biopsies work with conventional biomarkers. So if a biomarker is uncertain what it means, a liquid biopsy could clarify that. If you get enough material from a liquid biopsy, which is basically a blood test, then you could look for some of these markers. And by each of these little pictures, meaning a system, there'll be markers like the CA19-9 is colon cancer. Um, Over here, CA125 for ovarian, etc. So you can find all these markers which you could look for in these liquid biopsies, either to clarify a liquid biopsy or to augment or define liquid biopsy, give you the measure of the cancer marker as well. So the next thing you're asking me, I'm sure, is what does this cost? And this cost varies widely. Probably the cheapest I've seen of a semi-reasonable test was $500, and $3,000 would not be uncommon for either a test that covers multiple targets, covers a rare cancer, um, etc. Sometimes, tests are covered by insurance, but mostly not. And so these tests may be things that would be expected to pay out of your pocket. So if you're going to do this, you have to ask your doctor a few things. One, is this useful? Two, will they order it? Three, what will they do with the information if they order it? And do they know if it's covered by insurance? Now, the doctor may not know, but there's probably an insurance specialist in the office who could help you. And for many of these that are done by private companies, they often have, like very expensive drugs do, a a way to help you pay for this, maybe discount the price or something like that. So this is hot off the press. This is really brand new. This is a law that was proposed last year, and it's the Medicare Multi-Cancer Detection Screening Coverage Act. Like most things, has a super long name. And it was proposed last year, and it was literally passed last week. So this House bill passed into law, was passed by the House and the Senate, signed by President Trump just last week. And the important thing for you to know about this is it's going to mandate that Medicare pay for these multi-cancer early detection tests. And so that may make it possible for these tests to become part of routine screening. However, this coverage won't start till 2028, and it's only going to be targeted for people who are over 68 years old. That's the way this stands right now. But we're in 2026 right now, so 2 years more of development means that these studies, that these detection tests could become more sensitive and more specific. I talked about that. So better diagnostically, and the price will probably start to drop. So it may be by the time this law actually is enacted, some of the conditions of this will have changed. So, and really, the willingness to make this coverage possible is because of something called cost effectiveness. And that means if we take the cost of the test and we take the cost of either other tests that are commonly done, or the costs of remaining undiagnosed early, or the test not catching a relapse early, so is the cost of doing the test more or less than what we do in regular times now, conventional treatment? And it looks like for managing lung cancer, so selecting treatment for lung cancer and monitoring progress of treatment and checking for relapse, looks like lung cancer is one place where that's pretty good. So it looks like also there's generally agreement about using it for early detection for colorectal, gastric, breast, and some brain cancers. Um, however, now that I've said that, I have to ask this question. Are liquid biopsies really ready for general clinical use? This test that was done and published 2 years ago, about a year and a half ago, will answer that question for colorectal cancer. And we always have to ask, what are we comparing to? So in this case, they're comparing to not getting any screening. So this is the number of times they'll find a case. This is over a little over 7,000. If people don't do any of the routine screening that we do now, and regular screening is either a colonoscopy or a specific kind of stool test that looks for genetic material in stool. So this is probably a quote unquote liquid biopsy, but it's really the first application widely of using this finding genetic material in an excreted product from the body. Okay. So if we compare the gold standard, which is colonoscopy here, that's the yellow one. And you can see, boy, less than 2,000, like 1,500 new cases versus 7,500 new cases. Colonoscopy looks pretty good. And then this is that fecal immunological testing. And so now you have to say, how often do you do this test? This is doing the fecal test every year. Pretty good, just under 2,000, around 2,000. If we do it every other year, there'll be some that we missed that come up a year later. That's 2,500. But and then this is a different kind of test. So you can see, depending on the frequency of the testing. And these are the green ones are the liquid testing. So they're not as good as colonoscopy. You'll still find more things are missed than are missed with colonoscopy. Let's look at this a little more closely. So if we say what the testing method is, so circulating tumor cells, that's the liquid biopsy. It will decrease mortality 54%. So it'll cut down half of the deaths from people who never do any screening at all. Okay. And the frequency is every 1 to 3 years. Good. Then we look at stool testing. That's the Cologuard test. That decreases mortality between 70 to 80%. And that's usually done every 3 years. That you stool in a box, you mail it off. Colonoscopy, that's better, and more consistently better. But you only have to do it every 10 years. The main advantage of a colonoscopy, first of all, it's the best diagnostic test, and you get tissue to look at, usually, and everything. But the main advantage is that you're able to find polyps and precancerous lesions. So things that would turn into cancer if left there long enough. So the colonoscopy is still the gold standard. And It's better, it's less costly overall because although you say colonoscopy costs, let's say $2,000, this test might cost $1,000, and this test I think costs $600 or $700. Well, but you can do three of these. You could do, but at $1,000, you can only do two of these. So this lasts for 10 years. So its advantages not only that it's a better diagnostic tool, it finds precancerous lesions. It only needs to be done every 10 years. And partly the reason why you can wait 10 years is because you find the precancerous lesions. So right now, there's places for these things to be used, but so far they haven't made the case convincingly for being able to replace the gold standard. So here's the clinical bottom line, and this is what you could think about when you go to talk to your doctor. It's powerful technology. It really is powerful. And there already are some clinical things being clinical use. If you have lung cancer, breast cancer, colorectal cancer, you should be asking questions about how this technique can be used either with assessing your risk. Like, for example, if you have a BRCA gene, this might be a very reasonable additional screening test that you might want to do. Um, if if you've already started treatment, you could be using this to say how your treatment is going, to match you to a specific drug, or to check you for recurrence. So you should definitely ask if this technology is appropriate for you. You'll see that I put on the bottom of every slide some 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 uh, some studies that are in the medical literature. You can print out these slides and give them to your doctor. The reference will be right there. Or you could, for sure, make sure that you want to ask about this and make sure that you've organized yourself to have that discussion. But you have to remember a couple of caveats. This is a rapidly developing technology. So very quickly, and I mean every 6 months, there might be better methods. Better studies will have come out to show that a particular kind of test will be useful. Um, and they'll be covering more kinds of cancer types. So ask if you think it might be helpful. And then even if you ask once, ask again because it's important to keep asking this to make sure it's a top of mind for your doctor. Also ask if your situation is confused. If you get a test and you don't know what the meaning of it is, or you're getting a treatment but you don't seem to be responding, you don't feel like you're responding, then this is another thing you could do to ask for additional information to look at your response, look at your tumor, and see if there's more information that you could get that would help you and your doctor decide what should be done next.